7 warning signs of blocked arteries in your neck. Right now, inside your neck, 2 critical arteries are quietly carrying blood to your brain. And for millions of people watching this, those arteries are slowly narrowing, without a single obvious symptom. These are your carotid arteries. And when they become blocked, the consequences are catastrophic. We're talking about strokes, sudden blindness, and irreversible brain damage, often striking without any warning people recognized in time. Here's what makes carotid artery disease so uniquely dangerous. The brain has a backup circulatory system called the Circle of Willis, a ring of connected arteries at the base of your brain. This network can compensate for gradually narrowing carotid arteries for years, masking the disease completely. By the time symptoms appear, you're not in the early stages anymore, you're in a crisis. The blockage itself begins deep inside the arterial wall, at an anatomically vulnerable location called the carotid bifurcation, the point where your common carotid artery splits into 2 separate branches. Because of the unique turbulent blood flow at this junction, low-density lipoprotein cholesterol penetrates the endothelial lining, triggering a decades-long cascade of inflammation, plaque formation, and arterial narrowing that medicine calls atherosclerosis. In this video, we're going to walk through 7 specific, clinically documented warning signs that your carotid arteries may be dangerously blocked. These aren't vague, generic symptoms. Each one has a precise biological mechanism, and understanding that mechanism could save your life or someone you love. Let's get into it. Disclaimer: this video is for educational purposes only and is not intended as medical advice. Always consult a qualified healthcare professional for guidance regarding any medical concerns, diagnoses, or treatment options. All information provided is the result of careful research and verification. For full source details, please refer to the video description. 1. Sudden vision loss in one eye, amaurosis fugax. Imagine looking out of your left eye and suddenly watching a dark curtain drop vertically across your vision. Completely, silently, and without pain. Then, within minutes, it lifts as if nothing happened. Most people who experience this dismiss it as eye strain or fatigue. That is a catastrophic mistake. This phenomenon has a specific medical name: amaurosis fugax, derived from the Greek and Latin for fleeting darkness. It is one of the most diagnostically precise warning signs of carotid artery disease in existence, and here's exactly why it happens. The ophthalmic artery is the very first major branch of the internal carotid artery. That anatomical fact makes the eye the most direct downstream target for any debris originating from the carotid bifurcation. When atherosclerotic plaque becomes unstable or platelet fibrin aggregates form on a roughened arterial wall, fragments break off and travel upstream. These microemboli follow the path of least resistance directly into the ophthalmic artery and its terminal branch, the central retinal artery. When they lodge there, retinal perfusion stops instantly, and the visual cortex goes dark on that side. The vision typically returns within seconds to minutes because the embolus either dissolves or shifts distally into a smaller, less critical vessel. But here is what that temporary resolution does not mean. It does not mean the danger has passed. It means an active embolic process is occurring inside your carotid artery right now. Every episode of amaurosis fugax carries a significant short-term risk of a full hemispheric stroke, and it demands emergency neurological evaluation, not a scheduled appointment next week. 2. Sudden weakness or paralysis on one side of the body. Sudden weakness on one side of your body, in your face, your arm, or your leg, is the warning sign most people associate with stroke. But critically, most people don't know that this weakness can be transient, lasting only minutes, and still represent a medical emergency of the highest order. When this happens temporarily, it's classified as a transient ischemic attack or TIA. The word transient is deeply misleading because it implies safety, resolution, and time. It offers none of these things. A TIA is a stroke that ran out of fuel before completing the job, and the same mechanism that caused it is still active and ready to fire again. The motor deficits you experience are contralateral, meaning opposite, to the diseased carotid artery, and this is not arbitrary. Your motor pathways cross over in the brainstem at a structure called the pyramidal decussation. So if your right internal carotid artery is significantly stenosed and an embolus travels downstream into the right middle cerebral artery, which supplies the right primary motor cortex, The resulting weakness appears in your left face, left arm, and left leg. The middle cerebral artery is the most common embolic destination because it is the largest and most direct continuation of the internal carotid circulation. Clinically, this presents as facial drooping on one side, an arm that drifts downward when held outstretched, or a leg that suddenly gives way. When these deficits resolve completely within 24 hours, the temptation is to feel relieved. Instead, recognize it as your arterial system delivering its clearest possible warning before something permanent occurs. 3. Numbness, tingling, or complete loss of sensation on one side. Numbness and tingling are among the most underreported neurological symptoms in medicine, primarily because patients routinely attribute them to sleeping in an awkward position, poor circulation in the limbs, or early arthritis. When these sensations arrive suddenly across an entire half of your body, that explanation no longer holds, and the distinction matters enormously. The somatosensory cortex, your brain's dedicated sensory processing center, is located in the post-central gyrus, immediately posterior to the central sulcus. Specifically, the cortical branches of the middle cerebral artery supply this region for the contralateral face, hand, and arm, while deeper perforating arteries serve the leg representation. When a thromboembolus originating from a diseased carotid bifurcation lodges in these MCA cortical branches, sensory transmission from the opposite side of the body is immediately interrupted. The patient experiences this as sudden numbness, pins and needle sensations, or complete loss of feeling hemianesthesia that follows a hemibody distribution. This means the numbness doesn't affect just the hand or just the foot. It simultaneously involves the face, arm, and leg on one side in a pattern that precisely maps to cortical sensory topography. That distribution is the diagnostic key. Peripheral neuropathy from diabetes or nerve compression causes glove and stocking sensory loss or localized deficits, not sudden hemibody involvement. These sensory episodes can occur in complete isolation, without any accompanying motor weakness, which makes them even more likely to be ignored. A sudden, simultaneous sensory change across an entire half of your body is a direct cortical event, and it requires the same emergency response as a motor deficit or speech disturbance. 4. Sudden speech disturbances and language breakdown. Language is one of the most complex functions the human brain performs. It requires the seamless coordination of multiple cortical regions, subcortical pathways, and motor systems, all simultaneously. Because of this complexity, carotid artery disease that compromises blood flow to the dominant hemisphere produces communication failures that are as varied as they are alarming. In approximately 95% of right-handed individuals and roughly 70% of left-handed individuals, language is lateralized to the left cerebral hemisphere. This means that significant stenosis or embolism in the left internal carotid artery carries a uniquely devastating risk: aphasia. Expressive aphasia, Broca's aphasia, occurs when ischemia strikes the inferior frontal gyrus. The patient suddenly cannot produce words or construct sentences, yet remains fully aware and comprehending, creating a profound and terrifying internal disconnect. Receptive aphasia, Wernicke's aphasia, occurs when the superior temporal gyrus loses perfusion, leaving the patient generating fluent, rhythmically normal speech that is entirely nonsensical, while simultaneously being unable to understand what is being said to them. Distinct from aphasia, dysarthria results from ischemia affecting the motor control pathways of the facial, glossopharyngeal, or hypoglossal cranial nerves. The patient's language architecture remains intact. They know exactly what they want to say, but the muscular execution of speech is disrupted, producing slurred, slow, or garbled articulation. Both conditions represent acute neurovascular emergencies. The critical clinical distinction is this: if someone suddenly cannot speak normally, whether in finding words, understanding language, or physically producing clear sounds, that is the brain losing blood flow in real time. 5. Sudden loss of balance, coordination, or unsteady gait. A sudden, unexplained loss of balance, the kind that arrives without dizziness from spinning, without nausea from motion, and without any obvious cause, is a symptom that almost universally gets attributed to inner ear problems, low blood pressure, or simple aging. When carotid artery disease is the actual cause, that misattribution costs critical response time. While vestibular symptoms are textbook presentations of posterior circulation disease, specifically vertebrobasilar insufficiency, Severe bilateral internal carotid artery stenosis produces a distinct mechanism that also generates ataxia and gait instability. When both carotid arteries are significantly narrowed, the anterior and middle cerebral artery territories experience a dramatic drop in overall perfusion pressure. The regions most vulnerable in this scenario are the cerebral watershed zones, the borderland territories sitting between major arterial supply regions that receive the least robust blood flow under normal conditions and are the first to fail under hemodynamic stress. These watershed zones include critical portions of the frontal and parietal lobes that coordinate motor planning, spatial processing, and postural stability. When hypoperfusion reaches these areas, the patient experiences sudden gait instability, difficulty coordinating limb movements, and profound lightheadedness, without the rotational vertigo characteristic of inner ear pathology. Clinically, a key distinguishing feature is that carotid-mediated vestibulomotor symptoms occur in patients with established vascular risk factors, hypertension, hyperlipidemia, diabetes, or smoking history, and they appear abruptly rather than gradually. When balance fails suddenly in a high-risk patient, the carotid arteries must be investigated immediately alongside the posterior circulation. 6. Pulsatile tinnitus. The rhythmic sound in your ear. Most people are familiar with tinnitus, the persistent ringing or buzzing in the ears linked to noise exposure or age-related hearing loss. What they don't know is that a very specific subtype of tinnitus, one that pulses rhythmically in perfect synchrony with each heartbeat, is an entirely different phenomenon with an entirely different cause, one that points directly to vascular pathology. Pulsatile tinnitus caused by carotid artery stenosis is fundamentally a physics problem. Under normal conditions, blood flows through the carotid artery in a smooth, laminar fashion, organized, layered, and largely silent. When an atherosclerotic plaque significantly narrows the arterial lumen, the blood is forced to accelerate and squeeze through a reduced opening, converting laminar flow into chaotic, turbulent flow. This turbulence generates physical pressure waves, acoustic energy, that propagate outward from the vessel wall. The internal carotid artery passes directly through the petrous portion of the temporal bone, the dense, pyramid-shaped bone that houses the inner ear structures, including the cochlea. Because of this intimate anatomical relationship, the acoustic vibrations generated by turbulent flow in the stenos carotid are conducted through the surrounding bone directly to the cochlea, where they are perceived as sound. The patient hears a rhythmic whooshing, clicking, or pounding that accelerates and decelerates in exact synchrony with their pulse, because it literally is their pulse, acoustically transmitted through bone. High-grade carotid stenosis of 70% or greater has been documented as a cause of pulsatile tinnitus, and successful carotid endarterectomy, the surgical removal of the plaque, has repeatedly been shown to eliminate this symptom entirely, providing definitive confirmation of its mechanical vascular origin. 7. Progressive cognitive decline and mental slowness. Every warning sign covered so far has been acute, sudden, dramatic, and impossible to ignore once you know what you're looking for. This final warning sign operates on a completely different timeline. It develops over months to years, advances silently, and is routinely misidentified as depression, aging, or the early stages of Alzheimer's disease. It is chronic hypoperfusion-induced cognitive impairment, and it is caused directly by severely narrowed carotid arteries. The brain is metabolically extraordinary. Despite constituting only 2% of your body's mass, it consumes approximately 20% of your total oxygen supply and demands uninterrupted blood flow to function at any level. Chronic high-grade carotid stenosis doesn't always produce a single dramatic stroke. Instead, it generates a relentless state of reduced cerebral perfusion that drives two parallel destructive processes. First, repetitive subclinical microemboli from the unstable carotid plaque produce microscopic cortical infarcts, too small to cause obvious focal deficits, but cumulatively devastating. Second, the sustained reduction in perfusion pressure causes diffuse white matter demyelination, visible on MRI as leukoariosis, which disrupts the long-range connectivity networks that underpin complex thought. The frontal subcortical circuits are selectively vulnerable to this chronic hypoperfusion, and their deterioration manifests as declining executive function, impaired planning and organization, reduced working memory capacity, shortened attention span, slowed mental processing speed, and difficulty managing multi-step tasks. Because these changes accumulate gradually rather than appearing overnight, neither patients nor their families connect them to a vascular problem in the neck. The critical clinical distinction from Alzheimer's disease lies in the stepwise progression pattern, the associated vascular risk factor profile, and crucially, the reversibility. Early diagnosis of carotid stenosis and successful revascularization have been documented to halt further cognitive decline and partially restore function by reestablishing adequate cerebral perfusion. Give this a like, share with friends, and subscribe for more health tips made simple.